then his MCV was again roughly around 95. So again, when you're looking at these, most of the time you won't see these up around 100. They almost will never get up to around 100 if it's just a consistent B12 situation, unless it's extremely, extremely bad, and usually coupled with a folate deficiency as well. So more times than not, you're going to be seeing these somewhere in the realm of about 94 to 96 is kind of typically where you're looking at there. His homocysteine level was at a 12.9. So again, we've got some lab confirmation, and then just threw that HbA1c in there so you can see that there was some dysglycemic patterning here. And then he had the B12 deficiency. He had the folate deficiency to really couple this with, and then you can kind of see what his overall presentation was on his just his sex hormones here. They're all elevated, so he's not detoxing. He's not clearing at all. Case 3, 31-year-old female with chief complaint of weight loss resistance. She's over-exercising. So with that one alone by itself, if she's over-exercising, she's in a catabolic state most likely. She's breaking down tissue on a more repetitive basis, so she's asking more and more from her body to help heal and rebuild and repair that tissue. So 2 things here. One is that she may be just depleting her B12 from trying to replicate more tissue to try to repair and continue to rebuild that tissue she's breaking down from exercising. And 2, because of increase in cortisol levels to accommodate to that over-exercising, she may be wearing thin her gastrointestinal lining, that mucus layer, those secretory IgA molecules that keep that gastrointestinal environment healthy. She's probably decreasing quantities of those. That's increasing the opportunity for a malabsorptive state, that classic leaky gut presentation, and then you don't absorb B12 here. Poor motivation in general. You guys starting to see a little bit of a correlation between cases here. The apathy on the last case, low libido, additional lab findings, estrogen dominant. Okay, probably when you see estrogen dominant now, you should start to think about B12 with those cases. High triglycerides, elevated CRP, and low adiponectin. So her fat tissue wasn't sending the signals out anymore to uptake that glucose out of the bloodstream and stored as fat. So here's what you're looking at with her. MCV, just over 92, but she's there. Homocysteine, just over 7, not terribly over 7, but it's over 7. There's a need for B12 here. And I just put these in here so you guys can kind of see the rest of the overall picture here. She's got a lot of inflammation going on. And if that inflammation is not controlled, what's the likelihood of improving this B12 picture? No. Not very good. So, treatment intervention. Here's some different options for you. You can go with the oral B12 and folate, and we'll talk about looking at different forms here in a minute. But as I noted to you in that last study, studies clearly show the benefit of oral supplementation. So if someone says to you, well, I'm doing B12 injections, and I'm getting all the B12 I need, you're not. You're probably not, because most of those, I am seeing this get better, but for the most part, those B12 injections are not frequent enough. And the other consideration on that, and there's literature on this too, that if you supplement B12 or folate, if you supplement either one of those independent of supplementing the other, you're going to create a deficiency in the one that you're not supplementing. And and this was part of the reason I put that homocysteine pathway up early in this presentation, is so you can have a visual representation of where B12 and folate fall into that picture at, and how integrally they're related to each other. Your typical starting dosages on your orals, you can go to 1 to 2 milligrams. More times than not, I'll go 2 to 4 just to really push it, make sure we're getting higher levels, higher therapeutic levels in there. But there is a case for injections. So just think through those 3 previous cases I just brought to you. Which one of those would you typically think is probably at risk for needing B12 injections?
Celiac case.
The celiac case, right? And really what you're looking at is that the increase in that autoimmune presentation, we know that when one autoimmune tissue gets picked off and the immune system is dysregulated, the likelihood that it's going to go after other presentations is pretty high. So the 2 things you would want to check in that scenario are going to be your parietal cell antibodies and your intrinsic factor antibodies. I will tell you this from checking these, don't check just one of them. your likelihood of missing this presentation is pretty high if you just check one of these. I can't think of an actual case in my clinic right now where I've had both of these come back positive at the same time. It's either or, pretty much. And if you, the one thing you can do to trigger yourself into following through on this, apart from the patient showing up with the autoimmune presentation, is that if you see that MCV level is elevated, you supplement it, and in 4 months when you recheck that, you've given that 120-day time frame. If it doesn't correct in that 120-day time frame, start ordering these. There's some reason that oral B12 did not work. The protocol that I like to try to use when we're doing the injections is to do a loading dose on the front end of this, do a milligram injection every day for 7 days, and then do twice a week for another month to 2 months after that, and then you can go out to once a week. Here's just a diagram for you so you'll have a schematic of how these things all actually interrelate to each other.
Yes. On that case 2, was it the autoimmune presentation or the GI integrity that I mean, I know it's both, but if we see any autoimmune issue, do we need to start thinking that they might need IM?
If you see,
or only if it involves the GI?
Because it would have to have affected the parietal cells and the intrinsic factor.
Okay.
So if you, what I would try to do, if you've got an autoimmune presentation that comes in, and you know it's an autoimmune case, you run the CDC, the MCV levels are elevated, and you treat it for 4 months, it doesn't come down, then order those intrinsic factor and parietal cell antibodies.
Okay.
So just kind of to give you a quick schematic on this, the B12 comes in represented by these little pink triangles here. The intrinsic factor produced from the parietal cells. And these are the actual amino acid strands within these that the immune system can attack. That you have to bind those two together. It goes through the GI system, and you have to get it uptaken by these enterocytes down here. Okay, so you have just a visual to go through that way. Now, which form of B12 is going to be ideal for you to think about using with patients here? Because that comes up from time to time. And it actually also comes up not just with the orals, but also with the injections. And the typical B12 forms that you're going to see are cyano. That's by far the most common. And I'm also going to show you why it's by far the least ideal. Okay? But your cyano is most common, your hydroxy's out there, your methyl and adenosine. The latter two are the ones that we want to stick with, the methyl and the adenosine. And actually, when you guys are looking at this afterwards, go back and look at the slide where I showed the introduction of B12 actually going into the cell intracellularly, and there was a divergence of those two pathways. It actually talks about, in that slide, if you look at some of the names in there, it actually differentiates methyl and adenyl cobalamin and where there's a preference at. But in a nutshell, this is what that's going to be saying. If you look at, again, this homocysteine cycle, well, just logically here, if you're going from your homocysteine to methionine, and we're looking at the process of methylation, we want to offload a methyl group in this process, right? So it makes sense to have methylcobalamin here. And then you can also, to get to this from methylmalonyl-CoA over to succinyl-CoA, the adenosine is the one you typically see more involved in that particular pathway. Okay. So let's summarize this real quickly here. If your method of assessment does not assess B12, or does not assess methylation, it's not looking at functional B12 activity. Right? You've got to look at what the incorporation and utilization of B12 is. All patients should be screened for B12, especially the elderly. And again, there's so much utility you can get out of just a simple blood count. So now you just, that's one of the two most routine tests ordered in healthcare. So now you have a way of looking at that real quickly and going, okay, I see where this patient might be a candidate for B12 administration. And then lack of B12 and elevations in homocysteine can impact nearly every clinical presentation that you manage. You guys can go back into SpectraCell's blog. There's an article I wrote for them where I talk about the effects of homocysteine and some of the different ways to impact homocysteine. When I was doing the research for that blog article, there is hardly a tissue in the body that will not succumb to elevated levels of homocysteine at some point. Okay? okay? It may be at different levels, like I talked about, your cardiovascular, the literature shows more around 15, neurological tissue, you're looking more around 7. So there may be a difference in levels, but homocysteine will affect multiple tissues in the body, okay? And when deciding on which form of B12 to supplement, follow the biochemistry, follow those metabolic pathways. Anybody have any questions?
Is the B12 folate supplementation the only thing you do when you elevate homocysteine? Is that the main vitamin that would impact
It
that?
is. It is. Did everybody get that question? So when I have an elevation in homocysteine, I will typically look at administering the B12 and the folate. What scenarios would come up that I would differentiate from that? If a patient had a high homocysteine and a low glutathione level, then maybe I'm thinking about it's that transsulfuration pathway where homocysteine needs B6 to go down. Or if I've got a B6 deficiency and an increase in homocysteine, then I'm thinking that increase in homocysteine might be because it can't push to glutathione. But other than that, B12 and folate get it done most of the time. I've even experimented a couple of times with, even when I've got a B6 deficiency like that, B12 and folate still push it down.
Let me ask you a real rudimentary question, because that's where I am in all of this. When people have a deficiency in B12, is that, why is that? I mean, what are the different reasons that they're going to have that deficiency? Is it not enough proper food intake? Is it some kind of genetic flaw? What are we looking at? What kind of different reasons are there for the deficiency?
Okay, so to best answer your question, let's just go through the different points at which B12 could be interfered with, right? Okay, so let's start orally. First question I want to know is the patient consuming enough B12 containing food? We know that a lot of individuals out there don't consume adequate proteins in the diet, so we know we got to have adequate protein to get that in, right? Let's say that they're trying to subvert that by taking supplementation. Okay, the form of B12 could be inadequate for them. We know that the cyano and the hydroxy are not the better forms of B12. So that, and dosing, simply just pure dosing, right? So that could be an issue with them. Maybe on top of that, they're taking something, let me back up. Let me go a little bit deeper down in the gastrointestinal tract. So we're going from mouth now down to the stomach. Things that would impair acidity, lower acidity, because you've got to have adequate levels of hydrochloric acid to cleave that B12 off of your protein sources. So if they're taking, again, those proton pump inhibitors, antacids, or if they're just in a general increased state of stress, we know that an increase in sympathetic activity is going to downregulate parasympathetic activity, and if you don't have adequate parasympathetic activity, you're not going to get adequate vagal stimulation to secrete hydrochloric acid, right? So tell me who you know that's not stressed. who is not at risk for that just based on that one criteria alone? Okay, not to mention all the medication aspects of that. Then if you look at, let's keep going down, let's get into the small intestine now. B12 is absorbed in the distal small intestine just prior to the ileocecal valve. So if somebody has some type of malabsorptive state, if they have an inflammatory presentation in there, I mean, however you want to call this thing, intestinal hyperpermeability, leaky gut, it's all saying the same thing. If they have that, then they're not going to absorb B12 or a lot of other nutrients efficiently either. And then I guess you could work back up to the stomach, and if you've got an autoimmune presentation, you're not getting the activity of intrinsic factor or the parietal cell activity to produce intrinsic factor. So there's any number of ways that this could come about. You stack on top of that those medications. We had mentioned the metformin. That's just one. There's numerous ones out there that'll do it. The other big category is going to be your hormone replacement therapy, whether it's in the form of actually replacing postmenopausal, even in a premenopausal state, or if you're looking at oral birth control. Those are all going to deplete your methyl donors.
Alcohol.
So when,
Alcohol's another good one.
so with your expectations with supplementing, is with all of these other things going on, and assuming we're not really going to change them, is it a...
Well, why would we assume that?
Well, let's assume that. But my point is say some of those things will change for the better. but some of them probably won't, and some people may stay on medications, et cetera, et cetera.
Sure.
But then they would be on the B12 supplement as long as,
That's correct.
okay.
Because you've continuously got that interference in that metabolic pathway for them. And you can push higher levels of B12, you know, let's take the autoimmunity out of the picture for just a minute. You can push higher levels of oral B12, or even if you want to throw autoimmunity in and look at doing the injections, you can push those higher levels and get around a lot of that. But you've still got this underlying state of dysfunction there that needs to be targeted.